this baby had holes in part of the lung so that air was on the wrong side of the lung, pushing against the lung so that the lung couldn't do its job properly.
Hey everyone, welcome to HuMed episode number 4 or 5 or wherever we're at. And I'm your host, Dr. David Spiro. I'm a professor of pediatric emergency medicine in the Department of Pediatrics at UAMS and work as an attending physician at Arkansas Children's Hospital. But we are on a journey around discovering a little bit more the human side of medicine. Medicine itself is hard. Healthcare is hard and all the different things that we do. And the idea of this program is to really explore talking to colleagues of all different types of specialties and folks that work in healthcare and how does healthcare affect our colleagues as human beings. And today we are incredibly fortunate to have one of our trainees on who's a first-year fellow, just finishing his first-year fellowship. Oh my gosh, this year has gone quickly. Dr. Jonathan Williamson. Jonathan, welcome to the show.
Thank you for having me.
So why don't you tell the audience a little bit of how you got to being a pediatric emergency medicine fellowship, where you grew up and your journey to now.
So I am from Little Rock, Arkansas. I grew up in West Little Rock and went to Pulaski Academy High School, which I thoroughly enjoyed playing sports and having some good education there. I was able to go to Washington and Lee University for my undergrad, where I tried to keep an open mind on what I wanted to do, but I think deep down I knew I wanted to go into medicine. My family is all in medicine, and so I think a little bit of genetics, a little bit of exposure ultimately was a driving force. In college, I did an EMT course, and I trained one summer to become an EMT, did some ride-alongs and spent some time in the emergency department, and that was kind of the deciding factor for me that, yes, I do like medicine and I would like to be a doctor. So I, uh, I continued along with the pre-med track and was able to get into medical school straight from college. I was actually waitlisted though, and I got off the wait list about a week before graduation. So it was a pretty incredible graduation gift. In med school, I also tried to keep an open mind on what I wanted to do. I was telling everyone surgery for a while because that sounded fun to me, but I quickly decided on my third year surgery rotation that I did not love surgery, and you really need to love it to spend all these hours in the OR. And it was actually on my surgery rotation where I first really started thinking about emergency medicine. Um, I remember being in the trauma bay and as the trauma surgery medical student, and really being excited about that part, and then really not being excited during the going to the OR part, where I was proceeded to be stuck in the same room for hours on end, even though it was still enjoyable and I thought, very good experience. It's not what I wanted. Um, and then I got to my pediatrics rotation and really enjoyed being able to spend time around kids and families, and I find that the pediatric families are you're serving both the patient and the families, and families always seem to be very appreciative, at least a higher percentage I find, of an each side. So, um, I actually applied for general emergency medicine and pediatrics for the match, and so I wasn't sure what I was going to land, and I landed pediatrics, and I was really loved my 3 years of residency. But I think combining the two was ultimately what was meant for me, and so I'm really happy to be where I am now.
So that's a great thank you. And it's interesting. Every time I've had a guest on, I learn so much about the guest, and it's an honor to have you here today. And you and I share lots of commonalities because I also do not hail from Virginia. I went to college at the University of Virginia, and during my undergraduate experience, I took an EMT course and became a paramedic ultimately, and applied to medical school. Um, I was waitlisted at the University of Virginia, and so um, and I got in the week before classes started. So that was quite an experience itself. So I also relate to being waitlisted as well. So anyway, I'd love to hear. I ask all of our guests to have a story, which I don't know what the story is. And I don't want to know until you tell me the story, and I want to hear it live, like the audience will, and for the first time, and then we can talk a little bit about it. So tell me about a story that you have that's affected you.
So my story is going to come from my residency training when I was in the UAMS Neonatal Intensive Care Unit, and the scene will take place during a night shift where the residents there's one there's actually two night residents, one covering the nursery and one covering the ICU. And I was the third year paired up with a fresh intern. Um, and so I received handoff from all of the MICU residents. And there's this one patient in particular that I don't remember exactly what all of the diagnoses were, but likely a premature baby that did not have good lungs. And this baby in particular was having pneumothoraxes
What's a
and was
pneumothorax? Because some folks in our audience don't know medical terms. So can you explain what that is?
yeah, so basically this baby had holes in part of the lung so that air was on the wrong side of the lung, pushing against the lung so that the lung couldn't do its job properly. And so this baby had chest tubes in where there's small tubes sucking that air out on the wrong side. And this baby kept on having new pneumothoraxes, needing needle decompression, where we would put a needle into the baby's skin and tape away that extra air so that the lung can re-expand and do its job. And and at the beginning of the night, this baby was not doing well, and we were doing a lot of things to the baby and started feeling like we were doing more things to this patient rather than for the patient. And so at the kind of at the beginning of the night, we decided to really move towards redirecting care, which basically means that we're going to try to do less things to the baby and likely transition to letting the baby pass in a more comfortable way.
How old since the baby was born is the baby at this moment? Is it right after birth, or is it a week or two after birth? Where are we?
It was probably a week or two after birth.
Mhm, mhm.
And so we've been doing lots of things trying to keep this baby alive. And I do remember this baby was not an ultra premature baby. It was kind of the age where generally they have decent outcomes, these babies. And so there was lots of optimism. And so it was tough to move into that redirection, but I think the family was on board with that. And I remember we took out the first chest tube, and to try to make the baby more comfortable, and we were going to let the family hold, and all of a sudden the vital signs improved and the baby was doing well, and so at that point we did not feel comfortable continuing to redirect care, and we thought maybe this baby actually could make it, and so we stopped that and kind of moved on with our night shift. And so that is all in the background. The night shift goes on, and it's just particularly I'm not sure how all NICUs are, but it's always a crazy time over there because lots of it's the um, complex delivery area. There's probably a better word for that, but it's where all of the sick moms go when they need to deliver a baby, and and so there's always deliveries of sick children. And at the end of the night, um, there was a 23-week-old baby, the very kind of earliest that we're willing to try to resuscitate that was being delivered. And I couldn't get a hold of my attending, and so I went in and this 23-week-old neonate was born, and the attending was not anywhere to be found at that time, and they finally got a hold of the attending, but the baby was already out, and we had them in the resuscitation bay, and so that baby needed to be intubated.
which means putting a tube in the throat.
Yes, needed to help this baby breathe by breathing for them with that tube, and I took one attempt at this tiny baby, and I wasn't successful with that intubation attempt, and right around then is when the attending finally showed up. And during all of this time, the child from the beginning of the night was starting to crash again. Their vital signs were or is kind of going to what it was like at the beginning. Um, we had gotten an X-ray and looked like all those pneumothoraces had came back, and so uh, my attending and I agreed that I would try to do one needle decompression and see how things go, and then my attending would be there while my attending took over for this new neonate that had just been delivered. So we exchanged, and I ran over to that baby's bed, and I, for the first time by myself, I tried a needle decompression, and I was able to get some air out. Um, and it looked like it might have helped for a moment, but it seemed like we were still doing things to the baby, not for the baby, and so I ultimately decided that we're not going to do this anymore, and it is time to redirect care, and so we let the family we took the monitors off of the child and let the family hold their child and while the child passed. And so I was in the room to kind of facilitate all of that. And that was the first time I've ever had to do something like that, um, period. And then I was doing all that by myself without a supervisor or instructor. And so it was that night really stuck with me. And while all that was happening, the day shift slowly started to trickle in. Um, but kind of everything had already been done, and the baby eventually passed, and then my shift was over, and so I went home and wrote my notes and tried to fall asleep.
So tell me a little bit about that. So during the time when the baby was passing and you were in the room, what were you going through? Were you feeling uncomfortable? Were you feeling connected with the family? Were you feeling like you wanted to cry, or did you cry? Like, what was your emotional state when you decided this baby probably needed to pass? And when you came to that decision, talk to the family again, what were you going through?
So I had a lot of mixed emotions. I think one was pure nervousness and anxious that I was not doing the right thing. And then sad is an emotion that I could definitely say I was having watching the family cry. Um, haven't seen them fight for several days and nights in a row, and kind of come to an end. And for that same reason, a little bit of comfort because this was where we weren't putting the child through any more pain. And so in the back of my head, I knew I was doing the right thing, but I didn't have the reassurance of someone telling me that I'm doing the right thing. And I was nervous because we had the nurse and the respiratory therapists that were looking at me for direction. And I felt like I was stepping out of my comfort zone a little bit. I also embraced that, and so there was a little bit of nervous excitement that I was, I felt like I was stepping into my physician role and a leadership role, and so I appreciated that, but really, seeing all of you know, the fight was definitely sad for me. I don't think I cried in the room, but definitely shed tears later on.
Mm. So let me ask you about that, because we've talked about this in almost all of our first few episodes, and uh, Dr. Yu, Pele Yu, and I just had a very interesting discussion about uh, the fact that sometimes physicians don't allow their hearts and their emotions to come out while we're practicing medicine. And you and I are of different generations. So, what's interesting is when I was in training, I spent a lot of my time in the evenings, unsupervised. And you had described, and for those of you who don't know much about the way it works in training environments, that's changed a lot over the last 30 or 40 years. There was a lot of unsupervised care. In fact, our field that Jonathan is emerging into and I'm in, pediatric emergency medicine, the ERs were managed by pediatricians, and in the evening hours, the trainees were running the show. They were making independent decisions and doing whatever they felt that they wanted to, and they could have been a medical student 2 months before then. And now all of a sudden they're making pretty important decisions, and the curve has swung in a different direction, where there's much more oversight to the fact that in the pediatric ICU, in the neonatal ICU, and the peds ER on the floor, there's usually an attending around, monitoring what's going on. And so, um, but getting back, because we are of different generations, and for the audience to know, congratulations, Jonathan is getting married in a couple weeks, and is starting, and I met his fiance at Trader Joe's the other day. It's always uncomfortable meeting in Trader Joe's, and yes, but she is excited, I know, and Jonathan, and they're starting their lives together. She's an OBGYN at UAMS. So, uh, what in your generation, is it okay to cry? Like, okay, so you said that you felt it. There was stuff going on for you as the baby was passing and the family was grieving. Um, you were there to witness and support, and then you kind of dealt with it afterwards. But what do you think in terms of your generation? Is it okay to be emotional in the moment, or do you feel hesitancy around that?
I think it is okay to be emotional in the moment, but if you let your emotions dictate all of your actions, then that is problematic. So if I wasn't able to continue to lead, then we'd be leaderless in that situation. I think it's I think it's good to recognize your emotions and maybe temporarily compartmentalize for to really explore those emotions after the job has been complete, if you will. Um, I think it is important to show your emotions and to have the emotions, but I think kind of understanding when to really let them out is and being able to control when to let them out is something that's not easy to do.
What's interesting is when when I'm involved in resuscitation of a child that comes in into the ER presenting with cardiac arrest, so their heart is not working and there's CPR going on, and oftentimes when children have a cardiac arrest outside the hospital, their outcomes are usually pretty poor. In other words, they mostly die, or we can get their heart back and then they die later. Um, and we have protocols, we have algorithms to sort of follow, um, And we even have a timer and a person that's helping us with timing things when these happen. And what's interesting is when I'm in that moment, I don't let my emotions take over, even though it's obviously tragic that there's a dead child in front of us that we're trying to resuscitate. Um, and it almost feels as, if this sounds cold, maybe it is, but it almost feels a bit robotic that I can disassociate myself because we also do simulations and training. And this is kind of what we do. We practice going through the different stages of the algorithm. But I have found over the course of my career, when I end up sitting down with the family to oftentimes give bad news, that's when the human side takes over. And all of a sudden, this child had meaning in the lives of this family. Uh, and I have found over the course of my career, uh, I've allowed myself to become more vulnerable in the moment and, again, not go overboard and hysterical, but I'm okay with sharing with shedding a tear and expressing some of my true emotional state in that moment where I'm giving bad news. And in the PZR, giving bad news has its pros and cons. The pros are you don't know the family, and the con is you don't know the family. So when you know the family, like if you're in an ICU or a NICU like environment, you have a relationship, and you can probably better support a family. The vast majority of the time, when I'm giving bad news to a family, it's the first time I've met them, and that can be a really challenging time um, to to deal with that. Um, so what did you do after you said you went home and you tried to go to sleep? You know, you're post overnight, you're sleep deprived. What are the things that you did after the death of this child that helped support your self care?
Immediately after, I went back to my workroom and I just got to work doing all the documentation and some of the paperwork after a child dies. And I remember my care residents that were coming in fresh in the morning were telling me to leave and to know that they'll take over from here and I just couldn't quite, let the job go away and I felt like I needed to finish everything. And so I think that was one coping mechanism that I was experiencing was just continuing my job and not really thinking about, what had just happened. Going home though, that all kind of disappears and I just start playing the scenario over and over again. Did I do the right thing? In hindsight, absolutely, I did the right thing, and we had. It's not like we did this without talking with the family. The family was part of all of the decision making, and there's excellent communication between the our team and the family, and so that was great. The thing that helped me the most was the next evening coming to work with one of the attendings and just talking through the scenario with them and getting the reassurances and you know being able to talk about is the most helpful and I know we do that we try to do that in the emergency department after different traumas and tough patients of having debriefs. And so I think the just highlighting the importance of debriefing is something that's noteworthy.
Well, I appreciate it. For me, oftentimes I find talking to a partner, girlfriend, spouse, those kind of things help. I also find that for me, exercise helps. I just get out the sweat. And lately, the other thing that helps is just taking a walk with the dog and
That's what I do.
getting outside and
Yeah.
just being outside gives us perspective. And oftentimes, when one of my mentors, Cardin Johnston, unbelievable mentor at University of Alabama, Birmingham, he would, in the middle of his shift, he would just take off for about 5 minutes and have a little coffee outside. He would sit on a bench and just look at the sky, and um, it gives you perspective because, especially in the pediatric ER, um, fluorescent lights, loud noises, beeping sounds, which we tend to drown out to some degree, and then you have a bad event on top of it. Sometimes it's nice to just go out and have some.
Is there a rule against windows in emergency departments? All of the ERs I've been to have not had windows, and it's like the casino rules almost.
Well, we call it the emergency department, but many people call it emergency rooms. And 50, 70 years ago, it was a room. And that was where patients would go to get admitted, or if there was a bad event, they would go to the emergency room, and there would be an intern there waiting to deal with things. And then it turned into something bigger than that. I went to Romania as part of my residency after the curtain fell down, the Iron Curtain, and worked in some orphanages and spent some time at some Romanian hospitals. And they were probably 30 to 50 years behind what we did. And I got to walk into almost like what it was like practicing in the 1930s or 40s, with big wards and open seating, and families not allowed in the hospital, and an emergency room. There was one place where people could go to get in, and there were curtains and walls, and yeah, it's interesting. It feels like ERs would be better suited if there if there were windows and we had natural light coming in, and maybe it would make everyone less grumpy, because a lot of the families that we manage can be grumpy for good reason. But so if you were teaching a pre-med student, or you were sort of working with an early learner, and you are an educator, you're going to be an outstanding educator. What would you say is the major thing you learned, or a teaching point from the case that you took away, Jonathan, from this experience?
Trusting in your training and in your gut sometimes is the right thing to do, and you don't need to always have this algorithm that you're following. Um, but that's one reason why I don't think our job will be taken over by robots, is because being able to make changes on the fly, and even if sometimes maybe it wasn't the right decision to um, stop our transition of care at the beginning of the night, but I think it was probably helpful for us and the family, giving that baby another shot when things started to look like they maybe were turning a corner. Um, and so trusting your gut, talking with the entire team, and you know when when it's time for you to step up and be the leader, and they embracing that. And I I like what you were saying about how the shift has changed from back in your day to now, where there's a lot more oversight. And I think another takeaway as I become a transition from the trainee to overseeing other learners role is allowing the trainees to make independent decisions, and I can kind of be in the background to steer in a certain way, and I still crave that when I have someone overseeing me, being able to try to make the decisions, and be in that role. I do crave a little bit of that autonomy, but I think it's important to have oversight. And so just finding a good balance to where you can choose your own adventure without, making harmful decisions, obviously.
Well, it's been such a pleasure getting to know you as a resident, and now as a fellow, and now as a human being. I learned a lot from you about you sharing this story with us today. I know our audience is going to be happy, and want to thank you for joining us today.
Yeah. Thank you for having me.
This is David Spiro signing out. Please find us on any of your favorite podcast stations. And if you like this, subscribe. We want subscribers. Hope you all have a good rest of the day. Thanks, Jonathan.
Thanks for listening to HuMed with David Spiro, MD. If you like this episode, make sure you're subscribed on Spotify, Apple, or your favorite podcast platform. The video versions are also available on YouTube. Make sure you subscribe and hit the bell there so that you never miss a future episode.